Good afternoon. How amazing for us to be back in Vancouver. When I remember in 1996, we had the publication of the combination ART and the release of PIs. And my patients who had the ability to make it and hang on to 1996, so many of them are alive today because of that discovery. And how that is now translated into START. And Julio, congratulations. You've been telling us about this for 10 years and pushing us that way. And thank you to Dr. Tony Fauci for funding this absolutely groundbreaking study for all of us. I think what I'm also surprised about is how we've now taken science to program probably in a record time with a sneak preview of the normative guidance, which we will all sneakily take it forward. So it's just amazing to see all of that happen within 60 days, when it took us 3 years to do that for circumcision. So we're becoming so much more efficient and effective. And I just wanted to talk briefly about how we have really taken on board the concept of 90-90-90 and really during our 2015 COP preparation taken this very seriously. We've been working very hard to disaggregate data and dissect data to really understand where precisely we are. And so when we talk about where we were before PEPFAR and the global response, and you heard today about the changes in life expectancy and the number of people in treatment, but this last bullet about stigma and discrimination and how pervasive it remains, we can congratulate ourselves for how much progress we've made. But in some of these bullets, we've not made nearly the progress we have needed to make. And in the release of the UNAIDS report, this is the new data from the report, it also notes the pervasive nature of stigma and discrimination, including among ourselves and among healthcare workers delivering that care. So the challenge we have before us is how we translate this brilliant science into program quickly, utilizing the resources that we have and not using that as an excuse for lack of progress. When the fast track document came out from UNAIDS, it was a real wake-up call to me because it said this is where we're headed. If we continue to do the great work that we are doing together, we're going to have 2.5 million new infections a year, costing us over $1.5 billion additional dollars per year. And we don't have those funds. So that would put us back to that 1996 time when we didn't have adequate funding for people that needed treatment around the world. But then they said this is where we could be, 200,000 new infections per year. And listening often to Dr. Fauci talk about that we have the tools now to not take those and do it and make it happen together is really quite an important piece. And then in the fast track document it said we have 5 years. So, and we're in the midst of one of those years. So already 20% of our time has gone by, and we have to get onto this new graphic that will require us to bring together prevention, care, and treatment in a very new way. Now, the reason those numbers are the way they are and the reason we were headed to 2.5 million is because this wonderful demographic shift, this youth bulge that we're all excited about, has now resulted in 30% more women between 15 and 24. And how to embrace them and ensure that they remain HIV negative is a challenge to all of us, and it's what we must do together. And again, we need to do this in an era of we have level funding. But we have the ability to work together in new ways, and I think we have a unique opening between the political will that has been developed by UNAIDS and the expertise that's in the room to really take this to a different level and a different level of ability to provide prevention, care, and treatment. As you heard from Chai about this need to really do it and do it now, we like to call it the right things in the right places. We used to say at the right time, but then some of you know I'm a little impatient, so now we say right away and right now. So what have we been doing? Well, I think when we saw this data coming out of Uganda, and this was data that we, and this is new infections, this ever-rising graphic, and this was death. So when we saw this dramatic increase in new infections, we got together with the Uganda team, the host government, and we really looked at everything within the program to say, are we focused optimally to have an impact on the epidemic in Uganda? And they went through an exercise of core, near core, and non-core, but in addition, they looked at how the resources were focused. When they did this, they were able to dramatically increase the access to services, to circumcision, to prevention, to treatment in all categories. And now they've been focusing in a way where we've been using maps to really look at where we are providing services and is it aligned with the epidemic, just identical to what the CDC described was being done domestically. So I just highlighted one of these high burden areas, a high burden area just by quartiles, just demonstrating by the darkness of red the level of disease burden. And then we looked to see how were the services aligned, and did our services precisely aligned in this subnational district level to make sure that the services were being provided where the burden was greatest. And the good news is, if you look simply by quartiles again, the highest number of people on treatment are in that district. But then when you look at PMTCT and access to PMTCT, it's not the highest. And then when you look at children, it again is back to the highest. But then if you look at our orphans and vulnerable children's programs, the programs that are critical for adolescent prevention, adolescent retention, and also ensuring that children have access to treatment, you can see that that's where we're providing the least number of services. So the country was able to look at this and shift services, but the good news is circumcision was also focused in the same area. Now, some of you in the audience are so great at looking at Excel spreadsheets, but we sort of needed something that was easier to read, that turned data into something that was actionable in a quick way, and something that we could follow over time to make sure the changes were occurring. Now, this has been raised briefly by several of the previous panel and now in this panel, is we do have to look at our service delivery. In Uganda, we have 80% of the patients and 19% of the sites. I could show you statistics for country over country. In South Africa, it's 80% of the patients and 33% of the sites. Trying to understand what patients need at their sites and new models of care that look in areas that are very remote, have very few patients, to areas that have extraordinary number of patients and the quality that needs to be provided. The good news is when you put this all together and you did this analysis, the country, in partnership with the Global Fund, UNAIDS, WHO, the civil society, came into what we call our COPS, or a country operation plan, with these new targets. So if this is new infections, this is what our targets will be in the green for 16, showing this dramatic improvement in every aspect of the cascade, including viral suppression and measuring viral suppression through rollout of viral load in Uganda. You can also see in the light blue the gaps that will need to be addressed in 2017. But you can already see by the green on this graph how much progress can be made in a 12-month period when everyone is working together. I want to take you briefly through Haiti because it's a different situation. And again, this is deaths, new infections. In Haiti, when doing this same type of analysis, we had these areas of high burden where we had, and you look just quickly in the circles, inadequate services in each of these areas. And we had 80% of the patients and 30% of the sites. So they looked at everything carefully, and they came up with this term, which I love a lot. It said historically underserved populations. And they were historically underserved because of their geographic location, very high burden, difficult to reach. And so when they analyzed that and they saw it in those colors, they were able to say we need to focus programming there. Now, this is what we've all been able to do together since the beginning of PEPFAR and the Global Fund in Haiti. Together, all of these individuals have been served. And this is how many individuals additional will be served this year. But through this focus, with no additional dollars, they're adding twice as many patients to treatment this year and next year. And when you look at all of this together, it's almost a 40% increase of what we have done historically forever in Haiti. And this is what's possible when data is used for decision making in a different way. I want to end with the issue of stigma and discrimination. And this is a study done by FHI 360. It was funded by PEPFAR and done with USAID. And I just want to bring it back to that. These are healthcare workers. They did an anonymous survey, and they admitted to providing substandard care to people living with HIV/AIDS, to sex workers, and MSMs. They admitted to releasing the information about people's serostatus without consent, and they admitted that there was less care. The interesting thing is they didn't stop, FHI didn't stop with identifying how the healthcare workers were. They went to the clients. And there are many studies done on stigma and discrimination, but this study brought the two pieces together. And everything that the client was experiencing, the healthcare workers admitted to doing. And I think that this type of study is what we need, and that kind of data throughout our programming to look for these pockets of where we have to do additional education together to really eliminate stigma and discrimination. Now, in closing, we know that we have to, at PEPFAR, be more transparent so you can see our information, and we have to open up our COP processes. Now, this is like the fast track document, and this is how much people thought we had transparency previously. This is where we are now, and if we're going to succeed, this is where we have to get to. And we know that we have to provide information more in real time. We have to have it up on the website, and we have to have it available for each of you to really look at and dissect and understand. And so we want to end with a true partnership with each and every one of you, bringing continuous input from the scientists to program at all times, because this week, 34,000, and this is the new UNAIDS numbers, 34,000 adults will become infected and 20,000 will die. In any other disease, this would be unacceptable. I know it's unacceptable to each and every one of you. And it's just a privilege to be here with you in this moment, from combination, PI, heart, to now universal access for patients. Thank you.